Chapter 17 relates to ears and hearing. Uh, the ear is divided into three major parts. The external ear, which is from the ear that we can see to which is the ear that we can see. Middle ear is between the tympanic membrane and the oval and round windows that are where the inner ear begins, and finally the inner ear where this hearing is actually transmitted from vibration into nerve impulses that we can perceive. Structures of the external ear indicate the auricle, which is what you can see, also known as the pinna, and it is a funnel-shaped object that collects sound waves and conducts them into the auditory canal. And then the next portion of the external ear is the external auditory canal, and in adults it's going to be S-shaped. And then the lining of the external auditory canal is going to be lined with cerumen, and cerumen is what we know as earwax. It is a bacteriostatic substance, and it helps protect us from foreign bodies, but sometimes it can become impacted and give us some conductive hearing loss, as we'll see too. The middle ear begins with the tympanic membrane or eardrum, and then it's a cavity. It contains three bones which conduct the vibration from the where the middle ear begins to the inner ear. Those three bones or auditory ossicles are called the malleus, the incus, and the stapes. And then on the side of the inner ear, it's separated from the inner ear by a bony partition, and it has two openings in that partition, the oval window and the round window. What you'll be able to see when you take the otoscope and look at the tympanic membrane, you'll be able to see the handle and the short process of the malleus, which is the first of those auditory ossicles or bones. You'll be able to see the umbo, that's the base of the malleus, and that's pretty much at the center of what you'll see if you're looking at it properly. You'll be able to see the cone of light, which is a bright cone-shaped light formation. And then toward the top you'll find the pars flaccida, that's a less taut or tight portion, and then the pars tensa is at the bottom portion of the tympanic membrane. The inner ear consists of the bony labyrinth, and it's a fluid-filled kind of snail-shaped area, which contains where both hearing and the sensation of equilibrium are going to occur. The semicircular canals are filled with fluid, and there are hair-like sensors in this and in the what it's also called the organ of Corti, and there are two nerves attached to this area. There's the vestibular nerve and the cochlear nerve, and those two will combine to form the auditory nerve, also known as cranial nerve number 8. Conductive hearing is the first part of hearing. Vibrations are transmitted through the air. The external ear collects them, and then the tympanic membrane starts to vibrate as a result. Remember, it's sort of like we call it the eardrum, and so it's like the head of a drum. It will start to vibrate. Those vibrations then get transmitted to the auditory ossicles, and the stapes vibrates in the oval window and transmits this to the inner ear. So anything along that pathway that interrupts all of those that conductive process is going to result in conductive hearing loss. Sensorineural hearing occurs in the inner ear, and the movement of fluid in the labyrinth stimulates these receptors that line the organ of Corti, and then those nerve impulses from there, those nerve impulses will travel to the brain by cranial nerve number 8, the auditory nerve. So anything that interrupts that process, say if there's a problem with the receptors, if there's a problem with the nerve itself, anything like that can result in sensorineural hearing loss. Some of the causes of conductive hearing loss might be just impaction of earwax, as we mentioned. But also you could have otitis media. You could have a foreign body in there. You could have perforation of that tympanic membrane. You could have drainage in the middle ear, or otosclerosis, which is a process that occurs commonly with aging. Problems that can result in sensorineural hearing loss would include a dysfunction of any kind of dysfunction of the inner ear, or of the organ of Corti, or nerve damage. There is, besides the conduction of air through the air to the external ear, as we mentioned, there's also some bone conduction, so that even if your ears were covered, you'd still get some minimal amount of hearing by bone. It provides an alternate path, and will make use of this, as you'll see when we talk about the Weber and Rene tests. We make use of that. And so it involves conducting vibration through the bones of the skull. So we start, as always, we start with the history of present concern. What is the client there for, and what's the history of that present concern? Maybe they came in for a change in hearing. Maybe they came in for some other problem relating to the ears. So you'd ask about any recent changes in hearing. And maybe if they came in for other kinds of problems, maybe they don't really think they had any recent changes in hearing, but you would probably want to ask them if they have ever been concerned about a possible hearing loss, because many times hearing loss is insidious. We aren't aware of it until long after it's already occurred, and so that's why it's important to ask about that. If there is hearing loss, then the next thing to ask is, are all sounds affected or just some sounds? Maybe, for example, high-pitched sounds. That is common with hearing loss related to aging, is loss of the higher pitched sounds, but lower pitched sounds are still heard. Like I said, we can have other symptoms related to the ears. For example, we could have ear drainage, pain in the ears, tinnitus. Tinnitus is a ringing or roaring, or a sound that you hear that's not really there. And then dizziness or vertigo. If you have vertigo, there's what we call subjective vertigo and objective vertigo, but they are not the way we really usually use those terms subject and objective. In subjective vertigo, the client feels like she is spinning around and the rest of the world is standing still. And in objective vertigo is just the opposite. The rest of the world is spinning and the client is standing still. As far as health history, as far as personal history, you'd ask about any previous infections, trauma, earaches, any problems they've had before, and what treatment did they receive for that. And then as far as family history, any family members that had hearing loss. Lifestyle and health practices. One thing would be exposure to loud noise. These could be occupational or maybe military, it's fairly common, or perhaps a hobby, like does the person go out to the gun range and like to shoot guns and things. Or it could be perhaps use of headphones, use of listening to loud music with headphones, or frequently going to concerts where the music is played very loudly. What kind of ear protection does the client use when they're exposed to all these loud sounds? Do they use ear protection at all? Then another thing to ask about would be swimming, other exposure to water maybe, and do they use any kind of ear protection when they're doing that activity? If they have hearing loss, well then what effect has that hearing loss had on self-care abilities, on work, and on social activity? Also, you'd want to know when was their last hearing exam. Do they use any hearing aids, or have they used hearing aids in the past? And what ear care and cleaning practices do they do? So as we said, there's broadly two types of hearing loss. There's conductive, meaning that the pathway from the outside to the middle, to the inner ear, sorry, somewhere along that pathway there's something blocked. Or sensorineural, indicating the problem is occurring either in the inner ear or the nerve itself. But we can also have mixed hearing loss. Just because the person has conductive hearing loss doesn't mean they can't also have sensorineural. So particularly with older adults, as you get older, you're at increased risk for both kinds of hearing loss. So many times we'll have people with mixed hearing loss. We also describe hearing loss as being either congenital, meaning you had it from birth, or acquired, meaning that you got it sometime after birth. Some of the causes for congenital hearing loss would be if the mother had rubella, syphilis, or some other infections during the pregnancy, or if during the birth process itself maybe there was some hypoxia that damaged the auditory nerve or something. Or did the mother use certain ototoxic or toxic to the ears medications? One of the big offenders for ototoxic medications, one of the big offenders is gentamicin. But there are many others as well. Then acquired hearing loss, the hearing loss you get after birth, could occur as a result of meningitis, measles, mumps, an ear infection, or your own use of these ototoxic medications. Head or ear injury, or repeated exposures, or even just one-time exposures to noise can sometimes cause hearing loss if it's loud enough. Hearing loss can be bilateral or unilateral. It can be temporary or permanent. Presbycusis is what we refer to as the sensorineural hearing loss of older age. But as we mentioned, there's also an increase in conductive hearing loss with older adults as well. So turning to objective data, first we want to prepare the client, let them know what to expect, and obtain our equipment. And the main pieces of equipment we're going to need would be an otoscope and the earpieces that go with it, a watch with a second hand, and a tuning fork. We begin the physical exam with inspection, and we want to inspect the auricle, the tragus, and the lobule on the outer ear. And we're going to start by inspecting those for size, shape, and position. Then we'll palpate the auricle and the mastoid process. Tenderness to the auricle can indicate otitis externa, and tenderness behind the ear can indicate otitis media. And if there's tenderness over the mastoid process, that could indicate mastoiditis. Then we'll do an otoscopic exam, and we start by you'll see in the lab how to do it, the procedure. The key point is to get that auditory canal straight. If you don't pull hard enough to get the auditory canal straight, why, then you won't be able to see the tympanic membrane. But it's kind of if you aren't skillful in the way you do the exam and careful, you risk injuring the person. So that's why it's important to observe your instructor and make sure that you do things as she or he tells you to. But anyway, once you've pulled the ear and gotten the external auditory canal straight, why, first you'll be looking at the condition of the external auditory canal itself, and you'll see cilia along lining it and some earwax and this sort of thing. And then you will see the tympanic membrane at the bottom of that auditory canal. And you'll want to look at the color, shape, consistency of the landmarks. Then as far as the hearing tests, first we do the whisper test. And you only do one ear at a time, so you're going to have to cover the ear that's not being tested. You can ask the client to cover that with like a finger to the tragus. And you want to start with testing the better ear, so you're going to have them cover their ear with worse hearing in it first. Then you stand 2 feet behind so that they can't see your lips, and you will whisper a 2-syllable word. And then you proceed to test the other ear. The Weber test uses the tuning fork, and you put the tuning fork to the middle of the client's head and ask which ear the vibration is heard loudest. It's important to just touch the tuning fork by the handle. If you touch it anywhere, you strike it, and then if you touch it anywhere on the fork itself, you're going to diminish those vibrations, and they probably won't hear anything. So if you put it on and they say, well, I don't hear anything, why, maybe that's the problem. Maybe you touched it to the fork itself to your hand. But in any case, if the normal Weber test is that they would hear both the vibrations on both sides equally. If they hear it louder on one side, why that can indicate uh, if it's the side that they normally hear worse on and they suddenly hear it louder, that's an indication of conductive loss. On the other hand, if they have sensory neural loss, they're going to hear the vibration louder in the good ear. So why does this occur? Well, think of it as if you were walking around all day with your eye covered, one of your eyes covered. And so then we, at the end of the day, we get you in a room and ask you to take the cover off, and then the room is lit up. And you say, "Oh, that light is so bright in this eye," and that the reason being that eye has been covered, it hasn't been exposed to light all day. Well, the same thing, a similar thing happens with conductive hearing loss. Imagine that you have like a wax plug or something like that in your way. And so you hear mainly with your other ear, and that's the ear that's doing most of the work of hearing. And the ear with the conductive loss is getting a rest. But everything in the inner ear is still intact in that ear. So with the Weber test, we bypass that conductive loss. We're not relying on air conduction at all. The conduction's going straight through the bone, so it goes to both of the ears, but the one that has the hearing loss, why it's flooded with this sound that it's not used to, and it's like, oh wow, all this sound, and so you hear it much louder on that side with that normally has the hearing loss. In sensorineural loss, on the other hand, the vibration gets distributed to both ears, but since the problem is on your inner ear that processes that vibration, why it's going to be about the same as always. That ear will not hear the vibration that well, so the vibration will be heard louder in the good ear. The Rene test is kind of a variation on the same theme. That one, you strike the tuning fork, place it on the mastoid process, and ask the client to tell you when they stop hearing it. Meanwhile, you're timing this. Let's say that it was 10 seconds. So then at 10 seconds they say they aren't hearing it anymore. Then you bring it to the front of their ear and let them hear the vibration through the air. And ask them to tell you when they stop hearing it. So that they should maybe 10 more seconds, or about 20 seconds total time, why then they say they stopped it. So that's a normal result. The ratio of air to bone conduction should be about 2 to 1. Abnormal result would be, say, decreased air conduction. Maybe they only heard it for 5 more seconds. They heard it 10 seconds through the mastoid and they only hear it 5 more seconds. Or really abnormal would be if they didn't hear it at all after they stopped hearing from the bone conduction, and then you put it oh, I don't hear it at all anymore now. And that all of those abnormal results would be indicative of conductive hearing loss. Then we do a Romberg test, and be careful with this one. I've seen some students that are just sitting down and tell their partner, okay, now close your eyes, and stand there with your eyes closed, and they don't get up to protect their partner at all. Bad practice. If your partner fell, why then you would really be, or if your patient fell at the hospital, you would be fully responsible because you weren't there to try and catch them if they did. But in any case, you ask them to close their eyes, and you observe for swaying, or they may even shift their feet to to avoid falling. They should be able to maintain their position for 20 seconds with minimal swaying, with either no swaying or minimal swaying, and that would be the normal test. So some of the nursing diagnoses we could get, a health maintenance diagnosis would be readiness for enhanced verbal communication related to clients' desire to start using hearing aids or something. Some risk ones, risk for injury related to hearing impairment. So if you think about it, somebody with hearing impairment that goes out walking, they're not able to hear dangers like, say, cars coming up from behind or things like that. They aren't able to hear horns maybe when they sound, so they could be at risk for injury as a result. Then risk for loneliness related to hearing impairment as well. As far as actual nursing diagnosis, we could have acute pain related to, let's say, inflammation of the middle ear, as evidenced by reddened tympanic membrane. Or impaired social interaction related to hearing loss, as evidenced by client's expression, "I feel so lonely." Or impaired verbal communication related to hearing loss, as evidenced by difficulty conducting the interview. Collaborative problems and referrals. These are things that we can't take care of on our own and we need help with, or maybe we're going to turn over completely to another practitioner. Risk of complications for otitis media. Risk of complications from perforated tympanic membrane. Risk of complications for otitis externa.